Good morning, everyone. We are very fortunate to have here Dr. Andre Davila from BI, Beth Israel Deaconess Medical Center in Boston. He is a director of cardiac arrhythmia service there, and he is also the director of the Harvard Thorndike Electrophysiology Institute. He's been a household name in EP for several decades, actually. He was instrumental in the development of the pericardial puncture technique for epicardial ablations, which we use routinely. This goes back to 1995, right? And ever since, he's been back and forth between Boston and Brazil and continues to make important contributions in the field. And he is a leader specifically in VT ablation. Without further ado, Andre, we're very eager to hear what you have to teach us today.
Thank you very much. It's my first time in Houston. It's a great pleasure to be here, and thank you very much for the opportunity. This is not advancing, right? I can try to do it. There? Okay, I'm not sure if you knew about this, but Miguel and I, we go centuries ago. So I never knew, but when you go to Santa Teresa de Avila, which is a beautiful city in Spain, there are two castles there, famous castles, the Davila family and the Valdrabano castle there. Miguel's family did it much better than our family. They turned their castle in a very famous hotel. They have their own city in Spain. And my family had to escape to Brazil and start all over again. So, but here we are again. We are back in Houston, and the point that we are going to try to discuss with you, and please stop the presentation, ask questions anytime. Let's make it very informal here. I would like to talk to you about something that we care about, which is VT ablation. Why should you, general cardiologists, care about VT ablation? Well, VT ablation, it's a big problem. It's certainly one of the main causes of morbidity and mortality in the United States, especially with this aging population, patients with developing heart failure, as we were just talking a second ago. And of course, everybody feels comfortable about dealing with this problem implanting ICDs. But ICDs are far from being a good solution for VT. ICDs don't do anything in terms of preventing the next episode of VT. And if anything, ICDs are the most painful treatment for VT because you need to get a shock, which will cause a lot of distress to the patient there. And more important than that, if you keep getting shocks, this will have a paradoxical effect on your heart failure status, which can increase the heart failure and increase mortality. It's an interesting balance right there. On the other hand, if you treat these patients properly, and I'm going to try to tell you why we do what we do, I think we can offer a very good kind of approach and result for all these patients. So I like VT. This is my first paper in VT. I was a first-year EP fellow in Belgium. I trained with Pedro Brugada back in the day, and this is 30 years ago. And what I'm going to try to tell you is what exactly has changed over the last 30 years and the limitations that we are able to identify that would result in a not so interesting approach for VT 30 years ago. I think there was a huge change in the field, and that's what I'm going to try to talk to you. Going from the mechanism of VT, as you all know, we keep saying that VT is a reentrant arrhythmia, and over the years, there was a very, very important development in the understanding of the anatomy of these circuits, how we, as EPs, we interact and we interrogate and we understand the circuit. And on top of that, the development of this incredibly nice mapping system, as you can see here. This is a figure that was only possible for us to create like 10 years ago, and which has improved our ability to understand and treat the problem here. You see this incredibly nice map of this kind of VT, and over the years we were also able to understand that VTs are not only endocardial as we initially thought, but they're more of a 3D problem. Some VTs predominating on the epicardial surface, some which are exclusively related to the endocardial surface, but the vast majority of these VTs always having a 3D substrate there. Let's start from scratch. Any surgeons here? What would you do in a situation like this? This is a male Heart failure, ejection fraction distant. This is something that we used to see in the past, these massive anteroseptal aneurysms, right? These are patients with the proximal LAD infarct, and these patients come to the hospital with VTs, not an infrequent presentation VT there, and they are actually having PVCs and VTs despite of the use of amiodarone. So what's the best treatment option for this patient? You can choose the last two. Well, and this is exactly what the problem is, right? We need to know what we can do, but when you look at a situation like that, what you would like to offer is a good treatment for VT, which at the same time result in an improvement of the LV function. Because if you can treat a VT, but your ejection fraction is 9, this patient is going to die for a different reason in a short period of time. ICDs, as we were talking to you before, they don't do anything for the ejection fraction, and they don't actually prevent the next VT episode. If they do a good job there, they're going to actually treat the episode when the episode happens. But if you have, like, you go into VT storm, or if you have multiple episodes, being exposed to excessive ICD treatment can be actually bad for your heart failure condition. And of course, amiodarone, which is the only or the most important medication for the treatment of VT, has several different limitations there. And it seems that using amiodarone when patients are, or increasing the dose of amiodarone when the patients are already taking amiodarone doesn't resolve the clinical problem there. So our cardiac surgeon, Jatene, back in the day in São Paulo, this is like many, many years ago, Jatene had developed the technique to which they call it the double plicature to solve the problem of these anteroseptal aneurysms, which was good. They would remove the anterior wall aneurysm and at the same time create this double plication, shrinking the septal part of the aneurysm. And what was interesting is that this was developed to improve the ejection fraction. But since they were removing the entire substrate, or most of the substrate, they were actually able to present with good results for VT. So this is what's happening when ICDs were not available in Brazil. And look at the results. This is like a very long follow-up. The clinical results in terms of VT recurrence were actually excellent. But what you see here is that these patients had no VT, they were treated to ischemia, and they would have a much, much better ejection fraction, as you can see in this slide. I traced these ventriculographies myself, all of them, so I like these drawings here. So you had all you wanted to have. So you were able to treat ischemia, to treat VT, to improve the ejection fraction. And in spite of that, look at the overall mortality over time. So the VT population is a population that by themselves, they are very sick patients. Of course, we invest in VT treatment because what we can offer to treat heart failure these days and to treat all the risk factors is completely different from 20 years ago. And if we can put it all together, of course, surgery has no rule in VT ablation anymore, just in very specific subgroups of patients. But we need to understand that VT, what we can do for VT now is much better than what we are offering in the past, and also the management of risk factors and heart failure is way better. But another very important lesson from these days was that, well, this was done in the OR without any EP map. That's interesting. So in a way, depending on how you approach the scar, you don't need to map at all. And this is real, it's here. So this is the data that you cannot fight success. If you have this kind of results without mapping, we got to keep that in mind, that perhaps depending on the approach that you are going to use, the need for VT induction, which frequently results in cardiogenic shock during the procedure, may not be necessary in many patients, which then, on the other hand, will improve the possibility of doing more VT ablations in sick patients. But you just saw what the surgeons were doing, right? They were removing this entire substrate from the heart. So how is it possible that Dr. Valderrabano will take a patient with the same kind of substrate, massive scar, and treat VT with a 4-millimeter lesion? That's exactly what he's going to do. He's going to treat this condition here, this gigantic anteroseptal aneurysm. He's going to treat the VT with a very small lesion. How is that possible? How can we do this without removing the entire substrate? That's why we need to understand what the VT substrate is. So I had the pleasure, the honor of working with Jacques DeBakey in Amsterdam. Jacques DeBakey was a pioneer in describing a completely different idea in terms of what the VT ischemic substrate and in VT in general is all about. What you can see here is that this is the entire scar. The substrate for VT is not scar. The substrate for VT are the surviving bundles that connect both sides of the scar, two portions of the scar. And as you can see here, represented in white is dense scar, which has nothing to do with VT. And it's the black part that the surviving bundles come this way, and they connect this little portion to this one, connecting the two sides of the scar. That's the substrate for reentry. And that's very important to know, because if Miguel had to remove the scar and burn the entire scar, it would be impossible to do that with a 4 millimeter RF lesion. But if the substrate is this tiny little portion of the scar with surviving bundles inside the scar, that's why we can burn the scar and transform a gigantic scar in a non-arrhythmogenic scar, because you're specifically modifying the substrate that resides inside the scar. And that's exactly what the surgeons were doing by removing the anteroseptal wall and stitching the septum. By putting all these changes on the aneurysm, they would completely change the scar without knowing that they were actually treating these small bundles of surviving myocardial that cross the scar and are the substrate for reentry in most of our patients. What's interesting to know is that this small bundles of surviving myocardial, they can go from epi to endo and intramural. Depending on the substrate, you're going to have a prevalence of this surviving bundle sitting in one side of the wall. Let me give you an example. For post-myocarditis, for desmoplakin, for Chagas disease, the circuits, or for ARVC, the circuits are most commonly happening epicardially. For post-MI, they're more endocardial. So depending on the substrate that you're dealing with, you have to use different strategies to localize these circuits, to localize these small bundles of surviving myocardial. And we, swear to God, I'm not going to use many of these things. It's just for you to one of the things that we can do is to take the patient to the lab, and using different EP maneuvers, we can locate these bundles and ablate them all. And as you can see here, sometimes the bundles, so sorry, there's a change. So as you can see here, by localizing those bundles, I can apply radio frequency and stop my VT. I'm not changing the scar, I'm just modifying the bundle there. And if the VT is actually intramural, I can use different strategies, such as a bipolar application. I put my catheter on the epi space and on the endo space, and I can deliver some lesions there, which will finally result on the destruction of an intramural VT. These are options that we have to treat this. And as I mentioned to you, depending on the kind of disease that you're dealing with, you have to go to the epicardial space, because it's very difficult for us to create a transmural lesion with an endocardial ablation, or to get to the endo if you deliver an epicardial approach. This whole concept of epicardial was actually born in Brazil, because there was immense need for us to go epicardial in Chagas disease. And since then, it's been applied to many different types of diseases in patients there. What it does, it basically requires a dry epicardial puncture, placing a wire in the epicardial space, and then you have the space in your hands there. It's very important, because in some patients, the only substrate is located epicardially. This is a basketball player back in Brazil, and he had a completely normal endocardial surface. And there would be no reason for us to burn through the wall to get to the epicardial space. But when we went there, we found some interesting EGMs, and by delivering a RF, we were able to treat this condition. This is a different patient waiting for a heart transplant, came to the hospital in incessant VT. As you can see here, the endocardial surface is completely normal, and we deliver like an epicardial lesion back here. This is a great case, because the patient had a heart transplant 2-3 weeks after the procedure was done, and we were able to stop this problem with RF. Over the years, it became much easier for us to recognize when the circuits are endo, transmural, and epi. because by using image, using MRI and CT, we can now play with the substrate. And the information that we typically get from MRI and CT pre-procedure not only help us in terms of planning the procedure, making the procedure safer because we will know where the coronary arteries are, the phrenic nerve is. We can now understand the structure of the substrate and plan our procedure in advance. And what's interesting, we can also dissect those the bundles of surviving myocardial inside the scar. They cannot be seen by CT, but we know where they are likely to live. So we have these channels of wall thinning. If I have a huge scar, as you remember from the previous picture, I have scar and scar, very thin wall. In between, you have a wall that is not so thin and is graded between a very thin wall and a not so thin wall. This is where those bundles, surviving bundles of myocardial will reside. Will live there, and we can have a very good idea in terms of the likelihood of they living there using a wall thinning strategy prior to ablation. This is actually very important. That's how we get to ablation. But I'm going to try to talk to you a little bit about what exactly are we doing with ablation. Do you have any questions? Do you understand why we can ablate and how easy it is for us to plan the procedure? Surviving bundles, we can image, everything can be done. But the problem is that up to now, even though smart people, very intelligent people like Miguel are working hard on VT, we were not, as a community, we were not able to change mortality even with successful VT procedures. What we know, it's interesting because VT ablation reduces VT recurrences and reduces VT storm, reduces ICD shocks. And that's interesting because if we do all of that, how come we cannot change mortality? We have to think about the procedure a little bit. When we check a Kaplan-Meier curve such as this, and you see an immediate change, separation after the procedure, and if the groups are similar groups there, you have to consider that the procedure itself is the reason for the mortality in a specific subgroup of patients not to go well. It's easy for us as EPs to say, well, these patients are dying more because they have more VT recurrences, but it's not a good hypothesis, it's not a good explanation. First of all, because all of these patients that have an ICD, the VT episode will be treated immediately there. So we have to consider, we have to think a little bit more carefully that despite of all the image, all the things that we can do right now, if we do something that is not appropriate during the procedure, in my mind, and this has been my working hypothesis for a long time, I think the procedure can counterbalance the possible beneficial effect on mortality. We all know that every single time you have a patient in heart failure, if you stress the system, if the patient goes into acute hemodynamic decompensation, it's not going to help the patient. And that's exactly what happens in VT. So if you take the patient to the lab under general anesthesia, you keep inducing, you keep pacing, you can cause an acute hemodynamic deterioration, which will have an impact on early and the late mortality of the patient in 1 year. And as I mentioned to you before, this early separation that we see in VT procedures, we need to consider that perhaps the VT procedure itself is doing something that is not good for the patient. We can stop, we can eliminate VT, but in a way that can be too aggressive for the patient. And that seems to be a problem, specifically in those sick patients, as you can see here. It doesn't matter if the patient has a recurrence or not, if the ejection fraction is good. But if the ejection fraction is bad, after the procedure, most of these patients with or without recurrence, specifically those with recurrence, will have a poor outcome. Again, perhaps because we shouldn't be doing what we've been doing in VT ablation. And the reason for that can be easily explained by this slide here. Every single time I put a patient in heart failure, I have to shock him, I cause some acute hemodynamic deterioration. This has a continuous, cumulative, deleterious effect on the hemodynamic of that patient. Here, it's a patient who We shocked, we induced VF back to normal immediately after shocking him. In patients with a low ejection fraction, they never go back to baseline. The more we induce, the longer the procedure, the more hemodynamic deterioration they have, and they will never get back to baseline. Even when you put an impeller for support, we've done lots of patients using impeller to support our VT strategy. And as you can see here, this is the beginning of the procedure. This is cerebral oximetry that we're using to monitor those patients. Every single induction results in an acute, severe hemodynamic deterioration, which will have a cumulative effect to the point that here we would have to stop the procedure because the LA pressure was 32 in this patient. So it's clear that the strategy that we've been using to deal with VT is very complicated, because even though we need some of that information to guide our procedure, this can result in a poor outcome after the procedure. And that's a problem because, most of the patients these days, they do not tolerate the inducible VTs. In the past, when we have these massive scars, we would see more sustainable and VT that we could sustain and map and do all the tricks that we know to find a good spot for ablation. But these days, the pattern of scarring is different. Most of the patients that we see in the lab only present with very unstable VTs, which don't give us time to map, but yet can cause an important acute hemodynamic decompensation. The solution that the AP community found was to try to understand the substrate of VT without the need for induction. And as you can see here, we have two examples, US-made, Brazilian-made. So this is a beautiful activation map here that Dr. Tang has been using. All the information that you need is here. You see the isthmus of VT. You see the areas of block here, which are the transition between the surviving bundles and the scar. And you can pick and choose whatever area of the circuit you can to ablate. But as I keep joking with Dr. Tang, I said, this was a great study, but it took 2 weeks for the patient to leave the hospital because of the hemodynamic decompensation. This is a case that I did in Brazil. It's exactly the same substrate, but I was able to identify exactly the same components of the circuit just by simply RV pacing, without the need for VT induction and without the need for hemodynamic decompensation there. So that's where the field is moving to, now that we understand the substrate much better than in the past, we are trying to use different strategies to guide our procedure without the need for VT induction, without the need for acute hemodynamic decompensation, and potentially offer these patients all the advantages of ablation plus a mortality benefit there. I've been specifically working with different strategies. This is what Miguel doesn't like the name. I love the name, but it's okay. So what we are trying to do is to understand the scar by approaching the scar with different wave fronts. So I can pace from RV, from sinus, and LV pacing. Each time I pace from a different spot, I'm going to find a different kind of line of block inside of scar. Every single VT that we see in scar-related VT is somehow connected to a line of block, which makes sense. Without the line of block, there would be no reentry. Until recently, these lines of block were very hard to see, but with the kind of mapping systems that we have now, it's very easy to see these lines of block. And the way the line of block is represented, it's a function of the direction of the wave front, the direction of the way the front that approaches the scar. And as you can see here, when I use this wave front, I see my line there. Here I see a nice channel, and here when I do my RV pacing, my LV pacing, I have a wonderful channel there, a clear potential target for my VT ablation. What we are doing more recently, and Miguel, this is the first time I'm going to present this, is to combining all lines of block seen with different pacing strategies to better understand what's happening to the scar. So this is my line of block that I was able to see during sinus rhythm, combining with my lines of block that were only seen during during RV pacing. And now, when I bring my different lines of block here, I can actually give you all the components of the circuit without VT. I know that this part of the substrate seems not to be important. I have potential circuits here, which could result in VT too. I also know that after using different types of maneuver, this was the most important part of my circuit there, which is surrounded by areas that are not important. So using this kind of approach, I can clearly delineate my lesion set without the need for VT. And this is just a validation, and this is when we try to prove that these channels are important. Instead of keeping the patient in VT for an hour, we just do this for 10 seconds or so, quick evaluation to make sure those areas are important, and then we can cardiovert the patient if needed, and then we can ablate without keeping the patient in VT for a long period of time. And these are different strategies that we use, but as you can see here, you already know that our job is to identify those channels of surviving bundles inside the scar area, which are surrounded by scar, and that's why they represent lines of block. The channels are protected by 2 lines of block, and this is a beautiful case. It's an immense anterior MI, and I was able to identify this anterior channel here, and by ablating here, I eliminate VT, again, without the need for VT. And this is a very interesting case. So this is a patient with 2 metallic valves coming to the hospital on a weekly basis because of nearly incessant VT. Impossible to give him hemodynamic support, 2 metallic valves, aortic and mitral. And if we had to induce VT in this particular situation, patient was sick enough, so perhaps we would lose the patient on the table. So what we did was to use the kind of strategy that I'm just talking to you, which is find different pacing strategies to be able to identify lines of block inside the scar. And here, we had this very interesting line of block with a gap right in the middle, with a lot of slow conduction. You see every single color that you see here represents a portion of the cycle length. When you have this crowding, it's because there is slow conduction in that specific area. And I was able to ablate here using this Gerbaud approach, which is from when you come from the right atrium to the left ventricle, and without the need for induction, the patient had no more VTs after this procedure and died of heart failure 9 months later. So it proves the point that you can actually treat this condition without the need for VT induction. Let me just try to summarize this with a case. So this is a case that we did recently. This is a patient who had cardiac sarcoidosis. And again, the substrate for VT repeats itself regardless the underlying heart disease. It may change the location from epi, endo, mid-wall, but the substrate is always the same. Are surviving bundles of myocardial crossing the area of scar. So this is the patient. He had previous VT ablation, came back to us, and because this study, the MRI that we had from a few years ago, was suggesting the presence of an epicardial circuit, we went epi. The VT itself seems to be an epicardial VT. And as I mentioned to you, we're actually using 2 different pacing strategies. We have a catheter inside the coronary sinus branch, which will give us the opportunity to do LV pacing. And we use the catheter that is sitting in the RV, the ICD lead, to do RV pacing. So we're going to play with 2 different wave fronts. So when we create our little model there, you can see again the image that you are very familiarized with right now, which is 2 lines of block represented here in white, with a channel of viable tissue in between. So that seems to be an interesting target. As EPs, we use different tricks to make sure this channel is actually important. And as you can see here, what I'm trying to demonstrate is that we had 2 VTs in this particular case, which were induced during catheter manipulation, and we are able to find a perfect match when pacing from different areas within the channel. That's a very important piece of information for us. If you can match the VT morphology from within the channel, it means that that channel is very likely to be important. And look at this. Here I have my 2 mapped side by side. If I delete VT and LV, it's almost difficult to differentiate what is VT, what is the activation in sinus. Because as you can see here, my VT is like a reentrant VT coming this way, going through this little gap, which is exactly what we see here during LV pacing. In a way, if I had to ablate this patient without VT induction, I would have done exactly the same ablation, exactly the same lesion set. And that's what we did. We put our lesion there, which resulted in a very quick termination of a VT in a very elegant way, EP-wise. Not that you guys care about it, but this is a very elegant way of terminating this VT. The case summary is very clear, so we have to consider, we have to understand the structure of the scar to plan our procedure in advance. If you're going to go epi, endo, bipolar, we may not need to induce VT in many of these cases to have a successful procedure, and if we don't need to induce, this seems to help the patient a little bit better. This patient has been free of VT for the last 11 months. If I go back to my paper of 30 years ago, and I'm going to finish in 2-3 slides, I think we are in a perfect timing for VT ablation now. All those limitations that we're able to recognize as important limitations 30 years ago, in a way or another, we were able to deal with this. Initially, we thought that the large scars were impossible to approach because they're just too large. There's a lot of modification to be done. That seems not to be the case. Even in large scars, you have a few channels, potential channels for VT to sustain. And we can now understand the structure of the scar much, much better using imaging there. So the larger scars are not a problem. We could also understand over the years that the same channel can sustain multiple VT morphologies. So the point is not to be able to induce multiple VTs. The point is to be able to define the channel that can sustain multiple VT morphologies. That's checked out too. And since 1995, it became possible for us to map the epicardial space, which now it's no longer a limitation, which was a big problem in 1994 when that paper of mine came out. And not only that, sometimes you don't even need to go to the epicardial. Dr. Valderrabano has developed a very elegant way of ablating the epicardial extension of the scar, injecting alcohol in CS branches that are next to the target. So we are trying to work together with Miguel. I think this is a very promising approach. And I think, again, it's going to modify our ability to ablate epicardial circuits there. The last piece of the puzzle, let me put it this way, don't take me wrong, there's a lot more, but just to talk about the article of 30 years ago, is because during the last 30 years, EPs had this belief that VT is a functional problem. VT, the circuits are not related to the fixed lines of block. And that's why we are all obsessed about the need for induction. If the concept was different, if we understood the concept in a different way, meaning that lines of fixed block are the substrate for VT, we would have done a completely different approach over the years. We would spend more time trying to identify those channels in sinus without the need for VT. And I think we are approaching that time. Of course, Dr. Mark Josephson, who was the chief of EP at my hospital, Beth Israel, Mark was, the godfather of VT, a great friend of mine, great mentor, and we always had this discussion. I said, Mark, it has to be fixed lines of block, because how is it possible that we induce exactly the same VT 10 years apart? Well, we can't see the lines of block, and he was right. It was impossible to see. But with the new mapping systems and all these new approaches, it's becoming more and more clear that fixed lines of block are indeed the substrate for VT. And if that's the case, perhaps we can ablate VT without the need for VT, without causing hemodynamic deterioration, and which will potentially result in a very important benefit to the patient. If we look at our initial data, it seems to be possible to do that. As you can see here, the results are not bad, are comparable to the regular strategy of inducing. What is interesting is that in this particular subset of patients, VT recurrence did not increase mortality, potentially because we are not causing hemodynamic deterioration during the procedure. But you have to be careful, because in some of these patients, we are not able to see that the procedure itself made that patient more arrhythmic. The procedure itself made the scar pro-arrhythmic, which happens if you induce patients too. Sometimes you finish the procedure, you try to induce, there is nothing inducible, and the patient comes back to you a week later in incessant VT. So we are still trying to understand what subgroup of patients can benefit better from one or another approach. Clearly, if the patients have a low risk of hemodynamic deterioration in the lab, perhaps we can induce for a short period of time at the end of the procedure and try to define the result a little bit better. But on the other hand, if patients are in bad clinical situation, if the hemodynamic situation is not good, there is a need for us to ablate without VT induction. And I think that by studying the characteristics of the scar, this is just a suggestion, there are different other ways, I think we can get to good results without the need for induction. And when we bring these patients from home, since there is no hemodynamic deterioration, as you can see here, most patients go home the same day or next morning. That's huge for VT. Instead of keeping the patient came from home, we induced 10 VTs, patients in the house for 10 days, calling heart failure group all the time because the patient is not doing well from the heart failure standpoint. This is it's a massive change in the way we are approaching this problem there. And that's what we keep calling the Waddle approach, which is the ability to identify the wave front discontinuity lines, which is just lines of block there. There is nothing new here. It's just another way to visualize something that we know it's present. It's the substrate for a scar. And I just thank you very much for your very kind attention to this very boring talk. Thank you.
I was inspired by that paper you cited from your work in Brazil on surgical and the remodeling after surgery. And I'm happy that we have Dr. Lori here, who was one of the pioneers in surgical VT ablation. And my question to you and to Dr. Lori is, yes, we have evolved techniques to get rid of the substrate with catheter ablation procedures. We burn, and we may get rid of the substrate, but do you think there's a favorable remodeling that we're missing when a surgeon not only gets rid of the substrate, but actually remodels that ventricle? And that may lead to better function down the line. We don't change the ventricular geometry with ablation. Do you think there may be a role, will there ever be a role to reconsider surgical approaches?
Absolutely. I mean, one of the problems that it's a very specialized procedure, so you need like people with a lot of experience, centers that are devoted to that. Even with this approach in Brazil, with a very selected population, the mortality rate was 8% back in the day. So, but if you could approach the VT substrate and at the same time change the remodeling of the heart, that's the ideal situation for us. Unfortunately, that's not possible in many VT substrates like the non-ischemics, for instance. There is nothing for you to do there that will result in better LV ventricular function. But this is a subgroup of patients that benefit the most from the surgical approach, which is like these massive anteroseptal aneurysms there. And I can't speak for how easy, how different this kind of approach is, but if you can remodel, if you can change the geometry of the ventricle and treat VT at the same time, I would favor that approach tremendously.
I have another question now. We have a big group of imaging cardiologists here at this institution have been very powerful in imaging. And you alluded to the fact that with current techniques of imaging, we can start a procedure knowing where is the meat, where is the business of VT substrate, and where to look for. There's work on of course, MRI. There's work on CT scan looking at lipomatous metaplasia as areas that can be not distinguish a scar from an arrhythmogenic scar. Do you think we'll ever get to a point where we will just image before and forget about mapping, just go there and burn?
Well, we just published this like 2 years ago, I think it's impossible to use image alone for several reasons. The main one being the registration. So because you have to co-register the image to your mapping system. And even if you do the best possible job in the world, that's the stuff that we did many years ago in animals, you're off by 4, 5, 6 millimeters at best. And I love pre-imaging. It helps planning the procedure. It helps me go to an area that I care the most about. But I don't think image only can replace mapping, good mapping. Image can be better than bad mapping, but image can never replace a good mapping there. Having said that, there are some treatment modalities such as radiotherapy for VT, which are purely based on imaging. So, but if the patient is not in the situation that you're going to offer him like radiotherapy, imaging is very helpful, improves the safety, speeds up the procedure, makes you not waste time with areas that are not relevant to the problem at all. But they, in my mind, at this point, they can never replace a good mapping there.
Arvin, your question.
Thank you for a very eloquent presentation without too many squiggly lines.
I knew you were afraid of that. You were afraid of that.
Absolutely. The two questions, and one is you alluded the concept that we look at VT as a consequence of heart failure and a cause of death. But the dots between the burden of VT, of worsening heart failure, is not that well accepted. And I think some of the ablation studies, as you mentioned, probably have not shown that. But my question to you is, and we've seen, like when you talk about PVCs as an inefficient arrhythmia, we think about PVC cardiomyopathy, but we don't think about PVC burden as a cause of heart failure deterioration. And we've had a few cases where they get branded as advanced heart failure, needing VAD and transplant because you can't handle medications, but then Miguel does a PVC ablation, and then boom, they stabilize. So my question to you is there a burden of evidence that needs to be created to show a threshold of inefficient contraction because of inefficient rhythm? Right? We think about AFib as an inefficient rhythm, but I'm not sure in heart failure we have embraced the concept that X load of inefficient ventricular arrhythmia actually is a hemodynamic disadvantage, because you do see that with the VT that you talked about in the procedure. So I'm going to let you answer that and ask the next question.
The whole field is moving in that direction. You know why? Because it makes a lot of sense. So look at this just as an example. You get a patient admitted to the hospital today in VT storm, right? Almost incessant VT. Miguel ablates him, and he has one recurrence after 12 months. It's seen as a failure. It's absurd. So what we know right now is that Roderick Tang is trying to come up with this concept that if there is a reduction on his paper of 82% of the VT burden, this will have a beneficial effect on the way the patient will live for the next 2 years after ablation. It's all about burden, right? And the PVC concept applies really well here. So if you have a patient in heart failure that is having several episodes of ATP, successful ATPs, no pain, everything is going well, that's the ideal situation for you to take the patient to the lab, because he's having a huge burden of VT, which will probably result in some hemodynamic impact for him. So it's all about the burden. We know that the more ATPs they have, the higher the risk of developing VT storm. So why should you wait for VT storm? And again, how much VT is important? Well, VT is a very important problem. If you have one episode of VT, there is a huge chance for you to develop the second, the third, and the fourth. So when should you take the patient to the lab? VT ablation became a very safe procedure. I think the only way for you, the best way for you to prevent the next VT episode is ablation. It's not drugs, not other things. And don't forget, if monomorphic VT is present, this is a substrate problem. It has nothing to do with ischemia, has nothing to do with heart failure decompensation. A monomorphic VT implies the presence of a substrate that we can modify. A polymorphic VT is a different business, right? This is something that patients need to be better compensated, and that's important. But even if you have a patient with a monomorphic VT in heart failure, even with the best treatment for heart failure, the chances of having a recurrence of monomorphic VT is huge. So I don't know how many episodes you need to decide to bring the patient to the lab. It all depends on the experience of your center in terms of VT ablation. But the sooner you bring the patient, just like AFib, just like PVCs, the better.
But is there any data on, just to follow up on this, is there any data to show a threshold of non-sustained VTs, just like we say 10% PVCs? Is there a threshold of non-sustained VTs, not for VT storm, but more for heart failure exacerbations? Is there anything out there?
I'm not aware of that. We typically use the magic number of 18%, the PVC, if you want to. But we typically don't measure the non-sustained VT burden.
Yeah.
It's easier to measure the PVC burden. But if you get, if you have lots of non-sustained VT, again, we can image the patient, we can understand the substrate, and we can tell you, oh, this is an easy substrate that I can go and approach, even if the patient has no sustained VT. If it's a more complex substrate, intramural, some things that we anticipate a huge problematic procedure, perhaps we should treat him in a different way. But depending on where the substrate is located, this is a 2-hour procedure and can be done without too many risks, I think.
My second question is related to the impact of the procedure, as you mentioned. There's always an injury you're causing. So like we talk about the injury perpetuating inflammation, and while you're tempering the VT and hemodynamic compromise, is there any role for, there are a lot of anti-fibrotic gene therapies that are being postulated and worked on. Is there any role for suppressing your fibrotic or immune response after a VT ablation so that your immediate impact is reduced?
I'm not aware of that. But see, the substrate, the patient who have a VT after MI, 10 years after MI, the substrate is the same. There's little change on the structure of the substrate. So the genes, if there's anything they can do, is to kill the surviving bundles. I'm not sure if there will be a role for you to recover in terms of remodeling of the scar, because the substrates are very, very stable over the years. They're like MRI studies showing that. The problem is that after 10 years of MI, then you have the heart failure, you have a completely different autonomic nervous system, you have more PVCs, you have more triggers, you have more imbalance in terms of autonomics, and that substrate, which was not arrhythmogenic 10 years ago, becomes arrhythmogenic. But the structure of this, the structure of the substrate, even when you go from ejection fraction of 40 to 20, doesn't change much, to be honest with you. It's more the triggers and the remodel in the autonomic nervous system that will work in a way that will make it possible for patients to have VT now rather than before. The same way you have the patient at 82 years old is the first episode of AVNRT. He was born with that thing, but at some point in life, there was a perfect balance, a perfect storm, which will then result in an arrhythmia that he was not supposed to have at 82 years old.
Well, thank you very much for a really fascinating presentation. Brought back a lot of fond memories of late nights and prolonged hump runs. Just to go back a little bit, in the early days, blind left ventricular aneurysmectomy associated with VT in the United States was associated with a 50% cure of the VT. So Joseph's work, when he published it, was a big breakthrough because he got that up to 70%. And he did that by extending the resection beyond the surgical fibrous element and found a plane between the endocardium and the viable muscle, and it's his so-called endocardial resection procedure. That brought the VT rate up to 70%. When we saw this happening, I went straight to Dr. DeBakey and got him to fund a significant program here at Methodist to develop improved success for our VT surgery, and that focused primarily on developing a mapping system. And we were fortunate to have Matt Pruka here, who some of you may know. went on to develop mapping systems. And our system he developed here was, in fact, his first commercial product when he left us. So we had a system where we could do 60 simultaneous sites mapping VT epicardially and endocardially. And we used that, and I only really needed one beat of VT, so it was a very brief amount of mapping. And we found that by mapping, we were able to get our VT cure rate up to 100% for monomorphic VT, day in, day out. And what we also found, as you point out, is the complexity of these scars, which are often quite extensive. And we would find quite a significant disparity in the site of breakthrough for the epicardial and the endocardial data. And ultimately, we developed a approach of using cryotherapy with a 25 millimeter probe to ablate both the epicardial and the endocardial area, surrounding it by a significant zone of uncertainty. And that was ultimately the only way we finally got to the 100% cure rate. And if I understand correctly from your slides, you experience a 10 to 15% early recurrence with your catheter ablation. So I think mapping may still have a role. The anatomy alone, I don't honestly believe is ever going to find a single spot, because what we found, in fact, after we ablated some of these things, the original morphology changed to another morphology. And whether that was because the same impulse was traveling around some dead tissue, or whether another site lay dormant and then it became apparent, I don't know. But the sad thing is that we got this cure rate up to 100%, and in patients with an EF above 30%, our surgical mortality was 0. And we did 120 patients, and of course the defibrillator came, and everyone immediately stopped thinking about surgery. So even though I know I'm the only person here, maybe the only person in the world, saying that it's not a bad thing just to keep in the back of your mind that maybe there is another option when someone's in trouble. Map-directed VT surgery at its ultimate final development, before we went on to other things because there were no more patients being referred, actually reached a high level of efficacy. And Miguel asked me to summarize all this, and we published that recently in our in-house journal here, so he may be able to give you a copy of that if you're interested.
Sure. The main problem that we have these days is that the substrate is completely different from one Josephson proposed and was doing the...
Well, no, I just want to correct that. Initially, we were treating left ventricular aneurysm. We quickly moved on to people who had infarcts without actual aneurysm resection. And this same technique was highly effective combined with extensive ablation in curing VT.
Yeah.
I just want to make that point very firmly, that in people with an EF above 30% without left ventricular aneurysms, using epicardial and endocardial mapping in the operating room, we're able to ablate 100% on them.
We are not able to do 100%, but in ischemic VT, which is a completely different substrate, in a way it's much easier. We are very happy when we have a ischemic VT on the table. The problem is that there was a huge shift. So back with the endocardial peeling had these great results. It's all post-MI. And again, if we typically get 80, 90% success rate with the approach that we have. The problem, one of the problems that we have is, of course, when it's deep septal. But the issue with surgery, it's that when we have non-ischemics, it's different. It's a miserable procedure for us. It's very difficult to deal with the substrates. Having said that, I think it's the right time to revisit surgery, because now our maps have 10,000 points. And now the structure of the scar can be understood in a completely different way. The softwares that I was showing here, they were developed specifically to understand the scar. It's a typical MRI, but they process this in a completely different way. So I think that having the expertise in terms of VT ablation and combining imaging, mapping, Miguel can give you information before surgery that was impossible to consider in the past. Perhaps combining this in groups that have a good experience with surgery, it would be the best way to go. If the mortality rate is low and the success rate is high, why not, right? It's a great approach.
One last question.
I just want to make a comment that the problem that you face in the cath, during the procedure, hemodynamic instability despite the impella. So the septum is not just for the left ventricle. Septum is a pillar essential for the RV function as well. I'm a LVAS surgeon, that's how I know this. And when you do a septal procedures, if the septum going down, putting an impella because of the hemodynamic instability without the RV support is not going to help, and that's not going to change the hemodynamic problem, and maybe it's going to make it worse. So when we doing a septal procedures, I think thinking about the RV and the LV and the supporting both might be a better option for the future.
But what septal procedure are you talking about?
Ablation? Yeah.
Septal.
Yeah.
Yeah. Septal substrate is another horrible thing for EPs. We don't like septal substrates. We don't have a good way to deal with septal substrates. When we look at, there's some series showing that if you have a mid-septal substrate, your success rate is 17%, despite of a massive amount of, because we have a limitation, which is the ablation tool that we have at this point. Radiofrequency can go down 4, 5, 6 millimeters. So if it's a normal septum with like this mid-septal scar, it's almost impossible to approach for us. So, and I agree with you, in some patients we have to use biventricular support.
Yeah.
For the most part, even when you have a patient with a very low ejection fraction, using an impella 5.5 or using, I think impella, it's better for us. I understand the support that impella will give is not as much as ECMO and other strategies there, tendon, heart, etc., but it's just easier for the whole procedure, at least in our hospital. But deep septal VTs are.
But the impella is just for the left ventricle, and if you mess with the septum, your RV gonna get a problem too. And then without RV, if you put a 10-liter impella, it's not gonna help you. That's what
No, but that's what I'm
trying to
saying.
make.
So for
Yeah.
the most part, the impella is enough to help us during a short VT procedure. You cannot, of course, keep the patient in VT because the cerebral oximetry will get bad. But in a way, the impella, if you use impella 5.5, typically patients do extremely well hemodynamically if you don't induce all the time.
That was excellent. Thank you very much, Andre.
Thank you.
And this is the last grand round of decision.